here with us, and we are very pleased to be here. To be able to welcome you all today as we mark the launch of 2.0 version of CureSee. Before we get started, I'd like to express my sincere appreciation to all of you who generously helped us make this event come together because without you, we couldn't have done it. Now, I'd like to take this opportunity to welcome today's chief guest, Dr. Digvijay Singh. He is director of Noble Eye Care and surgeon at Noble Eye Care in Chennai. He has contributed significantly to ophthalmic sciences and pediatric ophthalmology. Welcome, sir.
I think there's some glitch on her network. Let me take it forward. So the chief guest for today is none other than Dr. Digvijay Singh. He is the chief director and surgeon at Noble Eye Care and is the president of Young Ophthalmologist Society of India. Sir has wide experience in the coveted All India Institute of Medical Sciences AIMS as well as Medanta also. We welcome you, sir, in our CureSee 2.0 launch event. Thank you so much, sir, for coming here.
Thank you for having me. It's my pleasure.
Zeba, if you can hear me, can you take it forward, please?
Yeah, sure. Am I audible now?
Yeah, perfectly.
Okay. So he has been a faculty in various national and international conferences and with over 70 publications, chapters, and books to his credit. He has contributed significantly to ophthalmic sciences. Dr. Digvijay is trusted by his patients to provide evidence-based treatment and in ethical manner. So we welcome you, sir. And over to you now.
Right. Thank you. I think it's indeed a pleasure to be here for this launch of CureSee 2.0. I have, worked with CureSee, the first format of CureSee, and that also has shown good results in our patients. And I'm dealing predominantly with pediatric ophthalmology, so we do a lot of amblyopia cases. And I've used it selectively in patients where I felt, that it was getting resistant amblyopia, and even in those patients, some of them were, as a primary form of treatment, and it has done well. And I'm very, eager to look forward to how CureSee 2.0 performs and surprises all of us even more.
Thank you, sir. Then we have a very eminent personality, Professor Monica Chaudhary. She is presently the Director, School of Health Sciences, Sushant University, erstwhile Ansel University. With over 3 decades of academic and clinical experience, she has authored 3 books and has received a number of awards for her achievements and in recognition to her academic contribution, including Shrestha Shri Award by the Delhi Citizen Forum and the Australian Leadership Fellowship Award. Welcome, ma'am.
Thank you so much. My best wishes to CureSee. Thank you for allowing us to be part of this panel. Wonderful. And we are happy to share our experiences that we had with the first version. As Dr. Digvijay say, yes, we did have resistant amblyopes where we've seen results beyond the books. And we look forward to some more coming in future with the new version. My best wishes to team who's developed it.
Thank you, ma'am. Then I'd like to welcome Dr. Aditya Sethi. He is consultant ophthalmologist in the Department of Pediatric Ophthalmology and Strabismus Services at Arunodaya Deseret Eye Hospital, Gurugram. He is also a consultant doctor at Sethi Eye Center at Delhi. Dr. Aditya Sethi has done his fellowship in pediatric ophthalmology and strabismus from esteemed institute Shankara Netralaya in Chennai. He has 8 years of experience in pediatric ophthalmology and strabismus, with many published case reports and articles in index journals. In pediatric ophthalmology, neuro-ophthalmology, strabismus, oculoplasty, and community ophthalmology. Welcome, sir.
Thank you so much, Ziva. And I'm very excited to share the panel with Monica ma'am and Dr. Digvijay sir. And I'm very excited to talk about CureSee 2.0 with everybody and get to know more about it. Arunodaya has been late to the party, but we've gone strong as far as the CureSee is concerned, and very excited to know more from everybody.
Thank you, sir. Now, I would like to welcome optometrist Sunil Kumar Dikshit. He is optometry in charge at Ahuja Eye and Dental Institute with over 15 years of experience in clinical and
Good evening, everyone.
Hello. Puneet, I'm audible.
Yes, sir. Please
Okay,
proceed.
okay. So I think there was some communication gap. So I think thank you, Jeva, for the wonderful introduction. And I'm well aware with the team CureSee as we are already doing here in Ahuja and Dental Institute for last 1 year, and we have excellent result and experiences. So I'm really excited and mostly awaited for this new launch of 2.0 so that we can just learn and understand what going on next. So I'm really excited. So thank you so much for the opportunity. Thank you.
thank you, sir. I think there was some network error, sir.
Yeah.
So next we have Dr. Rajiv Prasad. He is General Secretary of Indian Optometric Association. He is Director at Visual Eyes, a chain of complete vision and eye care solutions. He is also the founder of Eye Gurukul, an online learning platform. Dr. Rajiv Prasad has also served for 5 years as Asia Pacific Director for Health and Special Olympics International USA. Welcome, sir.
बैंक अकाउंट में दिक्कत है फिर यार वो तो फिर उनको यहाँ पे आके करना है तो कैसे होगा अकाउंट में करेंगे तो दिक्कत है फिर एक बार हमसे बात कराइएगा अभी नहीं थोड़ी देर उनको बोलिए कि सर से आप बात कर लीजिए कल
Then we have optometrist Abhinav Mishra. He is owner of Vision 2020 Optical and Rehabilitation Center, Lucknow, and giving his services in vision sciences for past 15 years. He has served at Bausch& Lomb, Carl Zeiss, Lenskart, and Ben Franklin as an optometrist and trainer, and now owns a clinic and states first of its kind setup where patients get a clinic service in low vision, vision therapy, specialized contact lenses, and basic needs for optical correction. Optom Abhinav Mishra has rehabilitated many patients through vision therapy and low vision aid. Welcome, sir.
So much, Deva, and my best. Thank you, Deva.
So we can't hear you properly. If possible, can you please bring the mic closer?
Okay, Deva, and team QRC and my best wishes to
20 कर दीजिए
also experienced the previous version of QRC and it was fantabulous to me. I think this one is going to be super fantabulous. Thank you and good night.
Thank you, sir. Now we have optometrist Sumit Kumar. He is a senior optometrist at Visual Aid Center, New Delhi. He has been a consultant optometrist with 9 years of experience in clinical optometry and places his emphasis on the satisfaction and well being of every patient. He completed his bachelor's of optometry from St. Stephen Hospital, New Delhi. He started his career as consultant optometrist and LASIK in charge in IQ Super Specialty Hospital. His area of interest are contact lenses, specialty contact lenses, low vision aids, myopia control, vision therapy, and refractive procedures. Last, welcome, sir.
Sir, you have to unmute. We can't hear you.
Hello,
Yes, sir.
am I
Now.
audible? Yeah, it's my pleasure to attend this type of innovative vision therapy event. And I've been using your software for the last more than a year, and I'm quite happy with the services and the software. And my best wishes to Puneet and their team for the new innovative and new technology. Yeah.
Thank you, sir. Now, I would like to invite Dr. Aditya Sethi, who will give us a talk on amblyopia, old disease, new regimens. Could you please share your screen?
It says host is disabled. Yeah, can you? Perfect. Hi. Can you see my screen? Yes.
Yes, sir.
Okay, perfect. So I'm going to talk about amblyopia, what's latest in management of this forgotten eye. So I'm Dr. Aditya Sethi. I'm a consultant at Arunodaya Desert Eye Hospital. I'm a fellow from Shankar Nityalaya, Chennai of pediatric ophthalmology. So no really financial disclosure here. And I have consents from patients. So like my guru, Dr. Minakshi, I would always like to start with a little case discussion. So we have a 6-year-old boy from Chennai, discovered to have decreased vision on school screening. Left eye was 636, best corrected, and right eye was 66. The refraction was about +2 in the right eye, and left eye was a +6, and rest of the exam was normal, and there was no squint. So of course, this was an anisometropic amblyopia. There was refractive adaptation, and there's occlusion which was given to the patient. So what's new here? Nothing really. But the challenge was ATS has made our life simple. It's told us how we treat amblyopia now with the occlusion, how many hours, is it as good as atropine or not? Yes, all the questions correct. But does it still hold? Now the dad was a doctor, so we had a nice discussion. So the dad said, "Doctor, when you are prescribing occlusion, aren't you doing precisely opposite of what you want to achieve?" So I said, "What do you mean?" So the doctor said, "Occluding one eye will prevent any binocularity from developing, right?" And I was like, So good food for thought, isn't it? So another case, 21-year-old, recently diagnosed to have amblyopia, wants to know if there's any alternative to occlusion. Had enough of this occlusion. Are there any alternatives? Any computer-based therapies or medication? Case 3, a 6-year-old girl, allergic to patch, has had photophobia with atropine also. So patching therapy, what does ATS tell us? It talks about patching therapy varies depending on severity of amblyopia. It says atropine is as good as patching. It says you need to give refractive adaptation before you start patching. It talks about amblyopia in the teens. It tells us about the success rates if the previously treated amblyopic comes to you. And it also talks about recurrence if you stop immediately and we need to taper. We all know that. What are the various behavioral treatments available now? So we have now what we call is the perceptual learning. Is my video and voice coming accurately?
Yes, sir.
Okay, perfect. So, what is perceptual learning? Any relative, permanent, and consistent change in the perception of sensory task following repeated practice. It's non-invasive. It's software-based. It's patient-specific. It's interactive. It's available as a mobile app, and patient sits in front of the screen wearing the best optical correction with dominant eye occluded. So, this is the latest. We also have these are different forms of perceptual learning. You can have stimuli and noise, you can have motion, you can have complex figures, you can have colors, textures, stereos, and fine forms. How does it work? It reduces by reduction of internal noise in the visual system or by improved efficiency in extracting stimulus, information by changing the relative weighting of the information. Is it the same as CAM stimulator? CAM is brief, it's passive, versus perceptual learning is active and prolonged. So what other things? We have video gaming. What is that? By playing action and non-action video game with better eye occluded. How does it work? It works by induced cortical plasticity and improved visual function beyond the sensitive period of the brain development. And video games induce a reduction of noise and an increased sampling efficiency, which is basically perceptual learning, as stated by Lee et al. So these are various games which have been studied. We have the Dig Dash, which is now available all over. Only thing, it often has addiction potential, especially with lockdown and children being indoors. Maybe a good idea, but it's a double-edged sword. Changing the focus from vision to binocular vision. Now talking about binocular vision. This is what we're talking about today. It's called dichoptic training. What is it? Contrast adjusted stimulus presented to each eye, brain forced to integrate into one perception. How did it work? Tasks in which stimuli are presented dichoptically with the contrast of the image to the fellow eye attenuated in order to encourage binocular combination of two inputs. So basically encouraging binocularity. And dichoptic stimuli are designed so that they perceive binocularly, a patient will be able to complete a task better, like we have in video games and CureSee. We also have now transcranial magnetic stimulation. A magnetic field is generated via plastic coated coil of wire placed on the head, induces a weak electrical current that stimulates cortical areas. Again, very, very early studies have been done about it. In pharmacotherapy, there's different rationale that dopamine has been found to reduce in the retina in deprivation of amblyopia, and increasing levels of dopamine in the retina may have a beneficial effect. So we have levodopa, citicoline, fluoxetine, which has been studied. Citicoline has been used. Effects are still a little controversial. Levodopa has been used, but PDIC showed no benefit in children. So, and fluoxetine has been quite disappointing. But what do we have to think about in the future? Watch out for the AMPLE study, which is coming in 2021 this year. And some acknowledges to my guru, and thank you. So I hope I was able to share some latest in amblyopia, old disease, and what are different new regimens we can think of. Over to you, Team CureSee.
Thank you, sir. It was indeed a very great and insightful presentation for us all. Now, I would like to welcome optometrist Abhinav Mishra. He will be giving a talk on amblyopia and how we should not be lazy to treat lazy eye.
Today's my topic is amblyopia. Don't be lazy to manage an amblyopic eye.
Sir, we can't hear you properly. Is it possible if you can remove your headphones?
Now, Puneet, I am audible or not?
Very less, sir.
Now?
Yeah, now it's good, sir.
That's good. Okay. So today's my topic is amblyopia. Don't be lazy to manage a lazy eye, because most of the time from not from our side but from our patient side, they get lazy to manage a lazy eye, because it's totally up to them how they can treat their patient and how they can guide their patient. So in a normal eye, I started with a famous monument of my city, Lucknow. It is a Rumi Darwaja, and if a patient see through an emmetropic eye, it shows like this. But if in an amblyopic eye, so vision sometimes like this, and blurry and cloudy vision is there. So what the features are affected in an amblyopic eye? So first is vision, then depth perception. Eyes do not appear together. An eye turn upward, downward, inward, and outward. Statics, if I talk about statics, so in urban areas it is 4.4 to 5.6%, whereas in rural areas it is 11.2 to 12.1%. This data is taken in adult person, because in the early stage maybe data are the same in urban and rural, but because of urban people are much aware about their eye care and about their health, so they regularly visit uh, they regularly visit their kids to optometrists or opthal places. So it is diagnosed early, and the data on my screen are very expensive in these urban and rural areas. Age group 2 to 4 years, 19 patient in a year, and 4 to 6 years, 63 patient. But a very huge number of patient, you people can see 135 in 10 to 12 years of group. It is diagnosed at this stage. It is not mean that amblyopia is present or amblyopia occurs at this age. This is all because people are not aware, and they do not get their kids eye checkup at the age of 2 to 4 years regularly. Once they went to their opthal or optometrist place at the age of 10 to 12, because at this stage it is a transition stage where kids goes for the cycle, kids goes for the football, kids goes for any other uh, activities. So this feels there is some problem in their eyes, they feels headache and they feels some depth perception, so they visited the optical places, and the data shows itself. Later, if we see 12 to 14 years of age group and 14 to 16 years of age group, so it reduced. Yes, obviously earlier we even we also read and we also know that amblyopia can not be cured after 14 years, but through modern techniques, modern therapies, it is curable and it is manageable. So in 14 to 12 years, the data is reduced, almost 9 patients reduced, and 14 to 16 years, it is 93 patient. Distribution of amblyopia. So refractive amblyopia 45.29%, strabismic amblyopia 40.36%, and deprivative amblyopia, it included cataract, ptosis, corneal scarring, and any other reasons 14.35%. Traumatic amblyopia also included in deprivative amblyopia because of some head injuries, it caused this amblyopia. So in some cases I saw improvement in traumatic amblyopia also. So I must included that vision therapies are really very helpful in traumatic amblyopia, so neurologists also can think about that vision therapies. Now, management of amblyopia, Aditya sir already explained everything. So I started with patching, slow results, daily life hamper, social embarrassment, and risk of reversal. But patching is a baseline treatment of baseline management of amblyopia. It also included in vision therapies, because we do patching while a patient and doing vision therapies exercises on this system. Penalization or an alternative therapy of patching. But the issues with penalization is light sensitivity. Though we use atropine 1% to penalize the correct eye or emmetropic eye, so but light sensitivity because of dilated pupil is occurred there. So sometimes patients feel discomfort in their daily routine. Vision therapies, pleoptic therapies, perceptual learning, CAM stimulators, and syntonic phototherapies, software-based, and pharmacological therapies. Pleoptics therapies perform in intense light stimulation at fovea to reach out eccentric fixation. Perceptual learning process in which training improves discrimination of basic visual features can improve adult and adolescent amblyoptic vision. Only in perceptual patient cannot see properly, but yes, he or she can perceive what it is or what it is not. CAM stimulator therapy is visual neurons activated by different spatial frequency grating and using a repetitive grating pattern with a sharp luminous edges slowly rotating through 180-degree. Syntonic therapies, application of selected visual light frequencies through an eye also improve balance in the body's regulatory system. Software-based VT, it is very much popular nowadays, and very seriously not popular, but it is a very result-oriented therapies nowadays. It improves eyes and hand-eye coordination, visual acuity, saccades, persuades, crowding, and visual memories. So we are using visual therapies for strabismus, also for headache, also for diplopia, also for dyslexia also. So these are the few things which we are using, on which we are using vision therapies. So the results are very good, I must say, because my few persons are improved 6.6 or 6.9 from 6.24 within 2 or 3 months of therapies. So it is very really commendable job by CureSee. Pharmacological therapies, as Adit sir already discussed about levodopa and citicoline. So nothing to add on these therapies. So exactly what is our mission? This is the main focus on us, because amblyopia is leading cause of blindness nowadays and upcoming few years. So like myopia control, as we are running a campaign against campaign for myopia control. So we also run a campaign for amblyopia generated blindness, because once amblyopia generated blindness occurs at the age of at adult age group, so it cannot be curable, and it can be curable, but it takes some time. Maybe results are varies from kids to adults, so it takes some time. So we don't need to rush, we don't need to get patient at the age of at the adult age. So early detection of amblyopia can cure amblyopia generated blindness. More focus on early detection through vision therapies must be CureSee. We as a practitioners can evade the time of patients, because CureSee is providing therapies from that can be handled, that can be do at home or at home. So it can be already evade the time of a patient, because sometimes patient get much time to commute from his place to a clinic. So we must think about that, and really commendable and really referable software CureSee. So after treating amblyopia, our monuments sees like this. You can patient can see our monuments and its beauty very much clear. Thank you so much. Connect me through these channels, and again best wishes to CureSee team, Puneet especially and Puneet Jatin. So do well and really appreciate your job. Thank you so much.
Thank you so much, sir, for a brief talk on amblyopia. Zeba, can we move on to the next presentation, please?
Thank you, sir. Next, we have optometrist Jayant Jha. He is founder of SJ Vision Foundation and also a consultant optometrist at RDJM Medical College and Hospital, and practice management consultant at Shri Jagatrani Vision Foundation. Welcome, sir. He will also be giving us a case presentation of CureSee Vision Therapy. Over to you, sir.
Thank you, CureSee, for giving this platform. Am I audible?
Yes, sir.
Yes. So I will be presenting a case-based approach towards amblyopia. So let me share. Yes, this screen is visible to you.
Yes, sir. If you could rotate it, then it would be in full screen, I guess.
Now it's okay?
Yes, sir. Now it's good.
Because now I am unable to see myself.
No issues, sir.
So it's a SJ Vision Foundation. Welcome you all on behalf of CureSee. And it's our approach towards amblyopia in Muzaffarpur, city of Bihar. We'll be dealing with a case. This is first case. Most probably this is the first case of our SJ Vision Foundation in Muzaffarpur. It's 15-year-old female with existing glass and all. I will not be reading all these things, but she first visited us with right eye poor visual acuity, diagnosed as amblyopia, and right eye was having suppression and stereo acuity was less. This was our approach. We have examined and we have introduced the vision therapy. And post vision therapy, you can see the results. This was just for about 1 week only, and then only this was the result. But we have introduced finally for 2 weeks, And then there was binocularity, stereo acuity was improved, and we have reviewed the case after 3 weeks. And everything was okay for the first visit, but in second visit, what we have seen that there was decrease in visual acuity, and stereo acuity was okay. There was no any disturbance in stereo acuity, and there is no disturbance in binocularity, but visual acuity has decreased in third visit. So what was the cause? The cause was a stopped patient has stopped the maintenance vision therapy at home. Then we again called the patient and counseled for office based, and we have named it as a booster vision therapy. So we have given it for 3 days, and then again we have reviewed after 1 month, and everything was okay. In this way, we have successfully managed this case, and finally we reached up to, for right eye it was 2025, and for left eye it was 2020, and then advised to review after 3 months. So this was the first case. Similarly, the second case which we have seen is was of 28-year-old male, and first we have seen on 4th January 2019. So refractive error and data, everything is given here in slide. You can see, you all can see. So what was there for the first visit? There was suppression in right eye, and stereo acuity was 800 seconds of R. So what we have seen that there was a difference in glasses, difference in RX of glasses, but with the change of glasses also there was no any significant visual acuity change. So we have introduced therapy, and we have processed with therapy, and what we can see that suppression, visual acuity has been increased, enhanced, but suppression has not been cured in first visit. So again, we have introduced the therapy, office-based therapy, and what we achieved, that we achieved both eye 20/20 visual acuity, and stereopsis has been enhanced, and binocularity was there. There was fusion, and again we have followed up with 3 weeks, and in this way we have managed this case. This was third case. 25-year-old female with existing glasses visual parameter, and with new glasses. Why I am writing this existing glasses and new glasses, I will be telling you at last. So left eye suppression was there, and stereo acuity was, gross stereo acuity was around 3000 seconds of R. It was present on and off since 6 years. Patient was on patching. Patient had very low self-esteem, and denial for effort was very high. She denied that nothing can be happened. But one thing I can remember her words today also, and for whole life also I will remember what she told, that सर अगर 5% भी विजन मेरा इम्प्रूव होगा तो हम कहीं भी जाएंगे और कुछ भी करेंगे. This was the positive thing in her, but everything was low. Confidence was low. For anything, whatever you will give, she was denying for the effort. But this was the good thing, and I have cast that and processed with vision therapy, and see, you can see that visual acuity has enhanced. Suppression was there for the first approach, and stereo acuity has enhanced, and we have reviewed her after 3 weeks, and successfully we have reached up to fusion, and stereo acuity was 200 seconds of R. And today also she is having 20/30 visual acuity in left eye. So she lost to follow-up and irregular for home therapy since 2 months. And again, she reviewed on 6 June 2019. And acuity was maintained. And we have advised for home therapy, continue for home. And
Sir, sorry to interrupt you in the middle, but Monica ma'am is asking if what's the refraction of left eye in that case?
Refraction was there. For left
in fact,
eye,
the slide before, I think there was some confusion. The right eye was written as +6. So I think this one he is given it right, the second slide.
This was in left eye, it was +6.5.
That's fine, because in the other slide you had given right eye as 6. Anyway, that's okay.
Okay, there may be some mistake. Right eye is plano only here. Right eye is plano.
Okay, sir.
Yes, thank you. Please go ahead.
Yes, thank you, ma'am. This was fourth case, 12-year-old male, and with existing glasses. For right eye it was 1.25, and for left eye it was 7.5 with 0.5 cylinder, 40 degree, and it was 3-month-old glasses. Visual acuity was for right eye 20/20 and for left eye 20/50. Near vision was N8 in left eye and N6 in right eye. Suppression was there. The stereo acuity was 800 seconds of arc. There was previous history of vision therapy at Amritsar. He was already introduced with vision therapy, and before therapy, his visual acuity was counting finger 3 meter. So it was a follow-up case from another consultant from Amritsar, and he resumed with us for follow-up and further therapy. And finally, he reached fusion, and visual acuity has enhanced up to 20/25. And I have lost this patient for follow-up because it was out-station patient. It was from he was from Nepal, and he lost to follow-up after this. But he managed well and reached his visual potential up to 20/20 and 6 in both the eyes. This was case 5 was of a 28-year-old female, and right eye visual acuity with -2.75, -3.25, 170 degree, 20/20, and in left eye -10 with -170 degree, 170 degree, 1-year-old glass, but she was using glasses since 8 years, and her visual acuity was 20/40 parts. Left eye was having suppression, and stereo acuity was 800 seconds of arc. So this patient had also no any visual improvement seen, but we have changed the glasses. We have introduced new glasses, and we have introduced vision therapy. She developed with amblyopia. She developed diplopia when she had. This was my first patient who developed diplopia and appreciated diplopia, and then we worked for diplopia also, and then finally we managed, and she had 20/20 visual acuity in both the eyes, and fusion was there, and the stereo acuity was 140 seconds of arc. This was a first case for us in Muzaffarpur when we started our work in Muzaffarpur. So this was 10-year-old male child, came for CL trial. Only this child came to us for CL trial. We did concluding classes. Parallelly, we introduced vision therapy, light therapy, and all, so that we can prevent amblyopia, because this was the critical age where we can intervene, and we did refraction and we did discuss contact lenses. This was the work of our contact lens department, but why I have kept this slide for this vision therapy was because we introduced vision therapy at this early age also, and we introduced vision therapy not only to the patient, we introduced to the parents also, so that we can prevent amblyopia. Because this was the case which will definitely, if we will leave this case without introduction of therapy, this will definitely lead to amblyopia. So here we have done preventive vision therapy. So what was our approach? The first line of approach for the amblyopia management, as an optometrist, we everybody had a role that we must do zero error refractive error correction. And this was the reason in every slide for first visit I have kept that with existing glasses and with our glasses, with existing glasses and with our glasses. So this is the first line of treatment. We have to give zero error refractive correction. And introduction to office-based vision therapy. And office-based vision therapy, what we did light therapy as well as we did software-based therapy. So this combination of therapy, we have not left any patient only for software. We have not left any patient only for light therapy and manual therapy. We did a holistic approach. That's why in every slide I have written SJ vision therapy. So this was our approach. We gave holistic approach followed by home maintenance therapy and followed by proper motivational and dedicated counseling. This was very much important. So with this 4 approach, we are managing the cases and we have managed all these cases. So thank you. And what we do here in Muzaffarpur is that we do binocular vision therapy, low vision care, specialty contact lenses, scientific optical dispensing we do, and this is my own area that I do practice management for optometry services. I do visit every clinic of optometry and ophthalmology wherever there is requirement of optometry services, we used to introduce that. Thank you.
Thank you, sir. It was indeed a very good presentation. Now, as many of you are already aware that CureSee have been working consistently over the past few years to move forward with the exciting update that makes CureSee world's first and one and only software to have artificial intelligence to enhance the treatment. So I would like to request Optom Puneet to take over the screen and tell us about CureSee 2.0.
Sure. Thank you, Zeba, for the introduction. Can you see my screen?
Yes, Puneet.
Thank you, sir. So today I'm going to reveal the 2.0 version of CureSee. Since 2019, when we began our journey, we were available in the vision care segment. But right now we have developed many more and many new approach towards amblyopia. So since our inception, we are maintaining uniqueness. These are some of the exclusive features available to us when before the 2.0 version. This was in the earlier version too. So we were the only software to work online, cloud-based, as well as offline. We are the most affordable software worldwide for vision therapy. We are available 24/7 as a support to patients and practitioners. We provide unlimited sessions for a complete 6-month package. We did provide live report update on practitioner panel as well as the same report onto the patient panel itself. Next is we do give you the commitment that the treatment of amblyopia is successful and can be successful in all ages, as it was proved in the ATS study also. The science that is used in the vision therapy software is random dot stereogram, RDS modules, the same that we see in the stereo acuity modules also. Next one is dichoptic principle, leading to crowding phenomenon, anti-suppression technology, combination of monocular and binocular exercises with the use of MFBF modules, that is monocular fixation in binocular field. We have individualized and customized contrast thresholds. So when we are targeting all of these components all together, the effects that we get or the results that we are getting is much more than patching. So this was what was available to us earlier. So what's new in 2.0? Why are we all here to attend this launch? So the first and foremost thing is artificial intelligence. I'm very proud to say that the world's only and the first artificial intelligence enabled software is made in India by CureSee. So what do artificial intelligence do in vision therapy? So artificial intelligence automatically categorizes and provides the patient with the best exercise based on their reports and based on the learnings, the machine learnings from the patient's performance earlier. So the computer system itself monitors the patient and then provides the patient with the best approach and the best exercises. That is why the artificial intelligence only. Next one is Gabber patches. Gabber patches is also exclusively available by us in India. That is, it is a non-invasive, patient-specific and perceptual learning program based on visual stimulation and facilitates neural connection at the cortical levels. To be in a layman manner, it improves contrast significantly in very less amount of time. So there are some contrast kind of gratings which are revolving, and we have developed an exercise around it. So the patient plays it for around 5 minutes at one time, and it is proven to show efficacy in the treatment of amblyopia in the studies being done in Asia and Europe. Coming up next is we have improved the user interface much more. As we have learned and we got the feedback, it's the end user, the patient, who should be using this daily for approximately many months, say 6 months or 3 months, depending on their severity. So it has to be very easy and user friendly. So we improvise the user interface overall. We improve the detailed and precise reports based on the feedbacks we have received from the practitioners. We made it easy, fast, and secure payment system so that it won't be a hassle neither for the patient nor for the practitioner. We made the exercises more fun and more gamified. We included the session as well as the package options, as many practitioners do wanted to give therapy for an n number of days only. So sessions are available. Anaglyph is now automatically shipped to the patient's address, so you don't have to check for your stock every time. Weekly email alerts are there for exercise summary. If the patient is not following up properly, the practitioner would get weekly email alerts as well as the patient would. Next, this is the patient panel. So as you can see, there are many exercises. Each exercise is available in a binocular as well as a monocular module. Exercises are much more gamified. Yeah. So in the above panel, there are, let's see a video first. This is just a glimpse of what the patient would do. Patient of any age can be treated now if he or she is having amblyopia and being diagnosed correctly. So what's included in the patient package? The patient would get a dashboard of gamified exercises which are changed daily. That daily he will get new exercises, so he won't get bored for a complete duration of the treatment. So he will get new exercises daily based on the help of artificial intelligence. Next is live exercise reports. This helps in keeping a check on progress. Whatever the patient is achieving, how many levels, how much score is he achieving. Coming up next is contrast setting. So contrast setting is used to customize your exercises. Next is FAQ. If the patient has any doubt, they can be covered. Downloading option is there for offline access by the patient. Suppose the patient belongs to a rural area, he can download the software and then access it without the need of any internet connection. Support panel is there for a smooth experience. So if the patient has any hassle, he won't call you in the midnight. We are there to handle him. Coming up next is practitioner panel. So this is what the practitioner panel will look like. It is a dashboard showing all the total number of patients, as well as your wallet, as well as due amount, with added features of billing as well as FAQ. So in the practitioner panel, you can access the live exercise reports of the patient. You can monitor your patients. You can have easy billing options. You can add the amount in either in wallet or pay directly for the orders, along with managing your invoices and orders. We have the support panel for the doctors too. complete patient controls are there in the panel of the practitioner, so that you can anytime monitor, change, edit, or even maintain the clinical findings of the patient there. If you have any FAQ, we have a section there also, so that each and every misconception can be solved there. Next is unique and advanced live report access. So this time we provided detailed and precise exercise reports of patients directly to the practitioner panel. So this is a small video showing how the reports would look like. As this is a dashboard of a practitioner, the practitioner would go to the name of that patient and click on reports. Next, he would see the entire annual calendar. The light one shows that no exercise has been done. The more darker blue it is, the more exercise is being done by the patient. When we click on that, we get a detailed info of the day, date, the time of the exercise, as well as the score achieved. Then we can see how much is the overall level in that exercise. So now the reports are very much precise and very much detailed for each day. So the patient has control that, the practitioner has control whenever his patient is doing the exercise or not, so that we can manage the patient accordingly. So what we are trying to give out our message here is enhancing your practice by adding latest services and adding value to the patient's life. As being a practitioner, to me and to you also, I guess patient comes first. And if the patient gets the latest and the most advanced modality, I guess there's nothing better than that in any clinical practice. Thank you so much. This is just a small bit from my side. Being at CureSee, I can guarantee you that we would be providing much more innovations in the coming future too. Thank you so much. And we are now open for a panel discussion if anybody has any questions or wanted to share your experiences with us.
I think that's very exciting. The new AI, which will help in facilitating the software and making it easy for all of us to get in touch with our patients and see how they're doing. And I'm quite excited. I think we just started about a month back with you guys, and we're already seeing some good results. So let's hope the CureSee 2.0 is even better than CureSee 1.0. And it looks like that. So congratulations to Team CureSee.
Yes, definitely, sir. With your support and guidance, we always strive to make the experience much more better for the patients as well as the practitioner.
Excellent.
Yeah, I think excellent. In fact, it beats all the science and the theory, as it is said that we are talking about amblyopia not in children with less than 8 years. We're talking about adults, and we've seen improvements coming into it. So that means it's one way, a message to all that whatever we have been hearing, the neuroplasticity is still continuing, and we can go in the older people also by this therapy. I would like to add that we have actually integrated contact lens, especially in an isometropic amblyopes, and then added this therapy. And there is an added advantage of cosmetic benefit to the patient along with the visual gain also, which has come in these kind of cases. The other next step to work on is, of course, the computer vision syndrome and improving the kind of performance and eliminating. I think it's more to work on those also by these vision therapies. Adding home therapies, as was the last presentation, is definitely good for a maintenance along with it, because at one stage we are trying to tell everybody digital, it's a digital world, and of course we are shifting from here to digital world, and that's why our old conventional patching therapies are moving on to this. But at the other end, we are also worried because of the overuse of the digital screens. So adding home therapies, which are manual home therapies, along with it, builds a better psych to the patient also. So that's few of my inputs. And once again, congratulations, Puneet, adding artificial intelligence. But of course, we cannot rule out the need of a practitioner in all these kind of things. Thank you.
Yes, ma'am. Thank you so much. Now, I would invite Dr. Rajiv Prasad to share a few words about his experience in vision therapy.
Thank you, Puneet, and thank you all of you. I mean, wonderful, session, wonderful panel, and I'm really excited. How CureSee is, coming up fast. The only thing which probably I would like to add here is, I have been doing vision therapy since last 5 years, and probably the highest age which I have done for amblyopia, it's like 54, and that too strabismic. And believe me, results was just awesome. And it works really great in like cases like anisometropic amblyopia, deprivation amblyopia, and also on. But at times when you select a patient for vision therapy, it is very, very important that make sure that the selection should be made in such based on the outcome, and the patient needs to really know that what they should expect. Because I mean, I see that as a clinician, the cases which like Jayant presented, the cases which our other fellow colleague, Mr. Mishra presented. Uh, a good workup is really needed. It becomes very for me, like if I present a case where I say right eye 2 and left eye -8, so definitely it's an anisometric amblyopia. But what was the versions? What was the NRA, PRA? All of these things really matters. And at times there are cases when I started way back 5-6 years back. I mean, there were cases where I got stuck. I mean, I did for therapy for almost 2 months, but there was no result actually. But now, gradually over the period of time, I've started learning. But one thing to ponder, especially nowadays, the biggest buzz across the globe is myopia management. And when we see a child, we always say that less of mobile, decrease the screen time. On the other hand, when we are doing amblyopia, we are actually contradicting our own words, saying that use the therapy for half an hour or 45 minutes and play the game. So it is very important to let them understand about the brightness which is needed, contrast which is needed, what should be the duration, what should be the lighting condition, in the environment they are setting, whether it should be, they have to switch off the lights while doing therapy, they have to switch on the light while doing therapy. And they also need to understand the outcome, because, if as a practitioner, if I don't say that, what they should expect and what I can deliver, believe me, it is not going to match at all, and patient will end up having dissatisfaction. So at last, I'll just say that it is a mix of a lot of other things. It is not only about software, and probably once me and Puneet we were discussing that the way gradually softwares are picking up, the message somehow is being passed that with software the amblyopia can be treated, but frankly that's not true. With softwares, yes, 20-25% work is done. It makes the thing slightly easy, but we cannot sideline the manual part, the other parts which is there, and the art and science behind this vision therapy. Because softwares, I mean, gradually this boom in softwares for amblyopia has come up, and I know probably 6 or 7 companies who has come up with their softwares. And there are cases where the failures are there. So just to let you all know that vision therapy is not only about softwares, it really all about the whole clinical approach, and each practitioner has their own way of approach. So based on that you can go. I mean, there are cases where I have I have a case, it's like a 45 years old male, exodeviation, hereditary macular degeneration. So he actually came to me for low vision. And the traditional way of doing low vision is magnifiers and telescopes. That is what being taught, and that is what being used all across the globe. But there is something called a spectacle based low vision which I have designed, and I have reduced the size of low vision. I have increased the size of vision rehabilitation. So in this particular case, what I did was I started with visual stimulation in my own way. I do a lot of light vision therapy, and currently in India we are just 2 people certified for syntonics light therapy, myself and Ravindra Pandey in Chennai. So we started with that, and believe me, with that stimulation itself, the person who was like 660 partial, with syntonics and with a bit of vision therapy stimulation, it came down to 624 partial. And then when we shifted them to low vision, so it worked out. And with spectacle based low vision devices, I mean, his vision is close to 618 partial. So at times we do, since I do about a lot of neuro vision therapy, especially patients who has lost their vision because of traumatic brain injury, concussion and all. So there is a inclusive approach, a wholesome approach, case to case basis. So it is not just one thing which is going to work, but it has to be a group of stuff which is needed. So wonderful CureSee. I mean, I wish you all the success. Excellent going, great team. Congratulations once again, and thank you for inviting me.
Thank you so much, sir. It was a pleasure that you are here. Also, I would like to add that diagnosis is basically what decides the management in that patient. So I completely agree with you, sir, that
absolutely
clinical guidance is totally required whenever managing a patient, and each patient is different also.
Correct.
Thank you so much, sir, for sharing light on this. Sunil, sir, if you would like to share a few words about your experience in vision therapy.
Thank you. Puneet, am I audible?
Yes, sir.
Okay, so I think after Jeev sir and Monica ma'am and all these 4 or 5 presentations, so I don't think so I have left anything technically to speak here. But as in I'm not a like therapy specialist and it's not my interest of area. But I think, but I never missed the opportunity to come in like flyer. So thank you for the opportunity to inviting me here. But if you ask to me regarding these kind of therapies, what we are doing nowadays, so I just talk about like practically how we should deal with the patients who has like amblyopia. So I just try to divide it these all the pattern in 3 parts. One, amblyopia. So suppose a patient who like came in the clinic and he's gone through all the examination. After the final retinal examination, the consultant has diagnosed for the amblyopia therapy, and then he said now you have to go for the amblyopia therapy specialist. So now patient come to you like when you are like a therapy specialist. So how the patient react to you? The patient react when you say क्या दिक्कत होती है आपको, तो पेशेंट किस तरह से रिएक्ट करता है? एक ही आंख में तो कम दिखता है, बाकी तो ठीक है, कोई खास बात नहीं है. So you just realize the seriousness of the disease. The patient is not aware with the seriousness of the disease. So patient how react? एक ही आंख में थोड़ा कम दिखता है और कोई खास बात नहीं है. But what you have to realize to your patient, what you have to realize to your patient, तुम्हें सिर्फ एक ही आंख में दिखता है, दूसरी आंख में नहीं दिखता है. तो अगर वो एक आंख में दिख रहा है और अगर वो चला गया, then you will be blind. So you have to realize your patient the seriousness of this kind of amblyopia. ये घर नहीं है कि 2 कमरे हैं, ठीक है, एक में सामान रखा है, एक में नहीं रखा, कोई बात नहीं. So it is a part of body. It is important to improve the vision if one eye has less vision. So counseling is a very important to convey your patient for these kind of advanced therapy, and simultaneously you can just focus on like divergence. So as the patients come with the EZO or exodeviation along with amblyopia, so you can explain these divergence can also correct with these therapy, and if there is any residual left, then you can go ahead for the opthal and then the squint management, and they can correct that residual. So now coming to the next part, which is a vision therapy. So suppose the patient asks, okay, now so you explain, so you started explaining the therapy. Once you explain the therapy, then the patient realize, okay, ये game खिलाना है, तो ये तो मैं भी जाके खेल लूंगा, इसमें खास बात क्या है? So what you have to realize, this is not the like normal game. This is something special which is particularly designed for you only. So you have to explain to the patient. Now here especially we are using the brain, eyes and hand, the coordination, and we have especially designed this therapy for you only. So this is the something is very special. So this is not like the normal game, तो आप जाके खेलने लग जाओगे, ठीक है? And the second most important part is age. The age is no bar to, you can attempt any patient at any age, जो कि हम कर रहे हैं, but what we are missing at any vision is also important. So sometimes we leave the patient when suppose patient have like 160 or 260 vision. So you can attempt those patients also, but under the GVP. So you have to explain the patient, there is a potential, we will try our best, but you don't leave the patient as it is with the refraction only. And if we talk about the simultaneously, the problem is we these two part we are doing very well, but the third part, which is outcome, like what finally we have gained through this journey, we don't work on outcome. So we have to proper maintain the data for every patient, and the patient who like referred from any opthal, you just go back to the opthal and explain this was the patient which you referred to me, and now this is the final result. So once you show the result to the opthal, then they'll convince, they'll refer the patient for amblyopia therapy. So this is the channel what I think all the practitioner has to go in a proper manner for the educate result. Thank you. So this was my personally opinion. So as I said, it's not my interest of area, but what I realized, because the Puneet and Jeva, they are already coming in Ahuja and Dental Institute for this therapy. So I have learned through these new optoms, and they are doing excellent. And my best wishes to the entire team, Puneet, Jatin, Jeva. Thank you so much for the opportunity which you have given to me to speak here. Thank you so much.
Thank you, sir. Now, there's a question in chat box by Dr. Rajiv to Dr. Sethi. Sir, if you could just enlighten us about screen time of kids who's myopic and has been on screen for his online study and now vision therapy.
So, like they say, there's no if there's no pain, there's no gain. So it's a double-edged sword when we talk about screens. Nowadays, classes are on screens. We are adding vision therapy on screens. That entertainment is screens. So yes, screens have become a big source of myopia. We all know that. The advice I generally share with my kids and my parents who visit me in my clinic is that screens are here to stay. There's not much we can do about it, but we have to have a balance, and the balance has to be with some sunlight exposure, physical exercises. I also stress on the fact that if we can cast whatever we are doing on a bigger screen and have a more distance from the screen, like a television rather than a phone or a laptop, it would be more beneficial. Yes, we also have options of blue filters in glasses and on screens nowadays. Even your Apple devices have it inbuilt. So do some of the laptops. Also, the certain amount of vitamins and lutein, zeaxanthin, toffees and all available to reduce strain. But again, the need of the hour is to get away from the screen. So physical activities, yes, that will help. But yeah, this is a necessary evil as far as amblyopia is concerned. And I think we shouldn't be concentrating too much on myopia progression when we are giving amblyopia therapy, because we are gaining vision. Maybe with a minus number, but we are still gaining vision. So yeah, you have to stay. This shouldn't be pushed aside.
Thank you, sir. Thank you so much. And I totally agree that our first priority is to gain vision. Then we can manage the refractive error then.
Correct. Absolutely.
So I think it's getting late now. Thank you so much, everybody, for taking out your time and joining with us. I highly appreciate your efforts, and you all came here with us to launch this 2.0 version of CureSee. Thank you so much, ma'am, and thank you so much, Rajiv Prasad sir, Dr. Sethi sir, Dr. Digvijay, Dr. Abhinav, Optum Sumit, Optum Sunil Kumar, Dikshit sir, Zeba, and everybody. Thank you so much for this.
God bless you. I think, Puneet, you've done a wonderful job and we're proud of you. Thank you. Thank you. Good evening, everybody.
Good evening.
Good evening.
Congratulations, Puneet. Wonderful job. Have a great day ahead.
Thank you so much, sir.
Good evening,
Thank you,
everyone.
sir. For joining.
Congratulations, Team CureSee.
Thank you so much, sir, for making this a huge success. It's all because of you.
Excellent, excellent work. See you.
See you.
Entire team of CureSee. Okay, I'm just saying congratulations to the entire team of CureSee for this wonderful achievement, and thank you so much for inviting me here in the panel. And still, I was just waiting. Are you going to share any more videos, or it's done?
It's done, sir, from our side.
Okay. Right. Okay, good. Okay.
Okay, thank you, Puneet.